Well, good afternoon, everyone. Welcome to the July 2021 quarterly Arkansas APCD Data Users Group. This is our 8th Users Group session. For those who are new to these sessions, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative and is administered by the Arkansas Center for Health Improvement. The Arkansas APCD is comprised of private carrier and public payer medical, pharmacy, and dental claims, including also enrollment information and provider data. Additionally, the ACHI, that's the Transparency Initiative, enables the use of key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics data, hospital discharge and emergency department data for self-pay and the uninsured, cancer registry data, and medical marijuana cardholder data. It's important to note that the data within the APCD is largely from fully insured plans that at present there are some federal rulings that dismiss the requirement for self-insured or self-pay plans to submit to APCDs across the country. They can certainly do so if they voluntarily do it, but they are not required under any mandate like fully insured plans are. So we receive what information we have about self-pay or self-insured comes from our hospital discharge data and our emergency department data, where we are able to pull apart these data and know which stays and visits were paid using a self-pay or self-insured plan. We hope that you find today's session helpful, and we invite you to ask questions at the end or reach out to our team after this session with any questions you may have. Next slide, please. So this is our agenda. We developed the agenda using survey responses from the last data users group. Some housekeeping for today. Between each section and at the end of the session, we'll ask for questions. Feel free to type your questions in the chat and we'll address them between the sections before transitioning to the next if we can. At the end of the session today, we will provide a link to our service desk application where you can enter any question and our team will respond. The Arkansas APCD data can be very complicated. Those of you who have used it know. You can also request time with our team to address specific questions you may have about how to use the data or interpret the data. The link to this deck will be provided in a follow-up email you'll receive at the conclusion of the session sometime today, most likely. And finally, the next data users group is scheduled for October 27th, 2021. So pencil that in on your calendar. So, but first things first, next slide, please. I almost got ahead of myself. Our speakers for today are, I'm Kenley Money. You've met me. And then Dr. Nicole Sanders, Assistant Director of Analytics, and Mike Motley, Director of Analytics here at ACHI. You hear from us a lot, but Mike and Nicole represent some of our users here at ACHI, and they always have very interesting things to discuss. So next slide, we are going to do something new today. If you've been in our sessions before, you know that at the end there is an email with a survey. Well, today we're going to take the survey as we go. We're going to collect feedback using an interactive presentation software called Mentimeter. Slides are placed throughout the presentation with questions about the topic that was just discussed, and a reference number is at the top of the feedback slide. And there's an example here you can see. And the number for the reference code for our session is 87037025. Don't worry, we'll show it again. And let's go to the next slide. Some of you may have used something like this. So then you'll need to go on your phone or a different browser to mentimeter.com. You see on your phone, or menti.com on a different browser. And when prompted, you'll enter the reference code found at the top of the feedback slide in the box. And there's this particular screenshot is from my phone. You'll see a screen with the question, the answer options, and then you enter your feedback. And I'm sure some of you have used this before. So let's try one. To begin, everyone, let's give you a second to go out to either the browser or your phone and name this first slide should be up. Name your institution, for example, UAMS, AID, etc., and your role with your faculty, student, researcher, professional, whatever. So your reference code is 8703-7025. Okay, and all of these will be recorded. So there's one. I know we have some ACHI folk, some UAMS folk. Don't be shy. Professor, thank you. Decision queue, great. Development lead, excellent. Excellent. Nice. Arkansas Tech, great. That's wonderful. Arkansas Blue Cross. Analyst. Wonderful. We'll give us another 30 seconds, say. Anybody else out there? Legislative analyst, nice. Biostat, the Bureau of Legislative Research, great. All right, last chance. Excellent. Let's move to the next one. You shouldn't have to enter your number again. It should have transitioned. There may be a button on your screen that says next slide. So is this the first time you've participated in the data users group discussion? I like new folk. It's great. – 17, wonderful. Give it a couple of more seconds. This one's easy. You didn't have to type too much. All right. Let's go to the next one. What is your analytic skill level, beginner, intermediate, or expert? Don't be shy. Give yourself credit. That's 15. I know there's 17 that answered the last one. That's 18. Okay, there's an extra. Great. And one more for this particular one. What types of health insurance administrative data have you worked with before? Click all that apply. Excellent. Good, good. I like all those who worked with provider data. Wonderful. Looks like we might be through with that. Kathy, that's great. Let's go to the next slide. So we're back to our agenda so we can stop having introductory fun and let's get to our first topic, methodologies for managing high collision hash IDs. Next slide, please. Okay. Okay. Stand by. There we go. This subject, methodologies for managing high collision hash IDs, is related to a topic we covered in the April 2020 data users group. It was called collision reduction methodology. The deck for that subject for that data users group is out on arkansasapcd.net. If you want to go back to it, you don't have to for today. It's worth reviewing again because as you work with these data, because we don't have personal identifiers, the hash ID becomes more and more critical. As you work with these data, you'll see that some hash ID groups can be very large. This section is to help data users manage them. First, to repeat a definition, especially for those who are new, the APCD unique ID or hash ID, you can see in that definition, is the hashed value that represents the concatenated member last name and date of birth. And you see the asterisk there in the data, it's field number ME998, the unique ID. Combining the hash ID with gender can be a proxy to identify a unique individual when supported by other information. The purpose of this approach is to determine a close approximation of the number of distinct individuals in a study population using a combination of the gender and the hash ID. So the Arkansas APCD does not receive personal identifiers. We do not receive name and address and social security number. So we can't distinguish cleanly between individuals or enrollees. So we use the hash ID as a proxy, and it works pretty well. You'll see in some of the next slides, which is the last name and date of birth, put gender on that, and it's a pretty good representation of an individual. Let's go to the next slide. Hash IDs are not as precise as using a complete set of personally identifiable information, as I just said. Collisions, quote, unquote, occur when last names, dates of birth, and genders are the same for more than one person. Collision influencers. Why might you have a collision? Twins of the same gender, common last names over time, common dates of birth within groups or years, and frankly, data quality errors. So if you have a lot of males whose last name is Smith that were born on the same day, they're different people, it's gonna look like that hash ID has a lot of records, but it's really for multiple people. So again, with this information we've covered before, but it's important to review the topic again. Next slide. Collisions, while present, do not occur often and have a very small impact on the overall data set. They sound very frightening, but they are not. Collision rate in a randomly created analytic set is expected to be around 3.5% or potentially lower for a smaller size set. So some of the numbers we're going to see are for the entire APCD database, but in your own small analytic set, the likelihood of a lot of collisions is pretty low. And we have found that if we identify them, we can identify them by grouping on them, that we can just drop them and it does not negatively affect the use of that analytic data set. Let's see some numbers. All right, Kathy. Great. So these numbers, these counts right here are for the whole database. So if you pull an analytic set, you're not going to find 4,900 of this first hash ID. And this hash ID, this count is at the rawest, highest level. So what I did was count the number of the latest enrollment record. If a person is enrolled in a plan over years, I took the active one. I didn't count that row for each year that person was active. It was the top one, the very last one. So this top hash ID that begins with 1Y and ends in E =, with concatenated with the gender female, there are 4,936 rows. And you can see the same thing for male and so forth. So those are pretty high, but are they really collisions? So let's look at the next slide. So I broke it down again and I found the submitting entity, and this particular entity represents Employee Benefits Division, and the numbers are the same. So I know that these hash IDs aren't shared amongst other carriers. And I did include, not all these represent the top 10 we saw before, but you can see that first column is the carrier, and a couple of them are shared across carriers. If you look at the last two, for example, that's a Medicaid member record, and 83470 is a Blue Cross record, and those people they're part of the QHP, Qualified Health Plan. So we have a member record on both sides. So there are lots of reasons why things look problematic, but aren't really. And our team can certainly help you discern the differences between them and which ones to keep and which ones you shouldn't. Right above that, you can see 60054A and then 47155. Well, 47155 is Delta Dental, and 60054A is a medical plan. So those people they have a medical plan and a dental plan, but it's not with the same carrier. So I would consider those appropriate. But the top two look very strange, and you might see these weird high numbers. And the point of our discussion today is to help you figure out why. So let's go to the next slide. Here are some reasons why. Data quality issues are the biggest problem. And sometimes sometimes the carrier submits data that isn't as clean as it could be. So blank names with default dates. Sometimes there are records that come to us. We don't see the personal identifiers, but they have a blank. The name, last name is missing, and the default date may be like 1900 0101, and all that's going to get hashed the same way. Common names and default names, John Smith, etc. Those are data quality issues that can create the same hash ID on all those rows. Now, sometimes you're going to see hash IDs with a lot of records that aren't really collisions. So this is where you need to dig, and why you need to dig deeper into the data to figure out what's going on. So some of the enrollees that we have are in treatment facilities, and they have lots and lots and lots of records. So so as you look at the data and you dig through it to look at other things like diagnosis codes and dates and that sort of thing, you will be able to pull apart what is real and what is not real. So let's go to the next slide. So to give you some perspective on the base, on the APCD overall, not just a small analytic set, the number of hash IDs with one member ID. So that means if I am enrolled in a Blue Cross plan, I have just once, I have one member ID and one hash ID. Then there are 1.4 million members, enrollees on the Arkansas APCD that just have one member ID to their one hash ID. And then you can see it progress. There are 2 million that have 2 to 5 member IDs. And when I use member ID here, I concatenated, I've considered the plan. So if I had a Blue Cross plan and a Delta Dental plan, then it would be one per hash ID. But you can see here that after the 2 to 5, and if a person has a dental plan, I actually contradicted myself. If a person has a dental plan and a medical plan, they're going to have 2 member IDs. Yeah. But that 2 to 5 row is sensible. It makes sense. On the Arkansas APCD today, I used to be covered by Qual Choice and Delta Dental. So I have a member record and a hash ID for those 2. And now I'm covered by Blue Cross and United. So I have 4. So it would make sense that my hash ID would have 4 member IDs. That is not a collision. But that said, you can see the numbers go down, down, down. Let's go to the next slide. And that it really represents potential collisions up in here represent almost negligible. It's negligible, not even mentionable, hardly, part of the data. Of course, as luck would have it, in every analytic set that I've ever pulled, there's one in there. But if you understand what it is and how to manage it, it is okay. So let's go to the next slide. Just to review, differences in member IDs are most often because a member was enrolled in different carriers over time. Member IDs can also change because of name changes, plan changes, and having multiple member IDs with a single hash ID is not always a problem. Next slide. So this slide will take you back to the April 2020 deck, because once you think you have collisions, you need to deal with them. And I don't want to spend a lot of time here talking about that. You can go back to the other deck, and we are happy to work with you outside of this particular users group to figure out how to manage that. So I believe I saw a question in the chat go by. Kathy, can you tell me what it was? Kathy's finding her mute button. Oh, wait, I think I can read it. Thank you. The question is, will a hash ID change, for example, if a woman gets married and her last name changes? Yes, it will change. And that's one of those management approaches for colliding hash IDs. So you would use your member ID to bring those together, and other data like date of birth and maybe zip code and plan name, that sort of thing. So hash ID, again, isn't as pretty as personally identifiable data, and you have to manhandle it a bit, but you can make it work with name changes. Are there any other questions? Nope. Then let's take our survey. Next slide, please. All right, everybody. The number's the same. If you still have your screen up, what did you find valuable about this topic discussion? Oh, wait, there's a question. While everybody thinks about what they're going to say, I assume we can't get back to I assume we can't get back to an individual from the hash ID, correct? Meaning I cannot look at a hash ID and figure out who the name of that person is. No, it is encrypted 2,000 to 3,000 times over, and you can't get back to that person's name. Okay, helpful. Good, good. Yep. Great. Okay. Last chance, and we're going to, there's one more question. Oh, there we go. Yep. Mm-hmm. Mm-hmm. Okay. Oh, yeah. Yeah. Different IDs by carrier. Mm-hmm. API. I think I want to move to the next question. What additional information would add value to the discussion? It's hard, I understand. And we can offer, when we send some follow-up information out, we can offer an opportunity to add more information to this. Mm-hmm, mm-hmm. Yeah. I'm gonna, how about 20 more seconds? I've got my trusty phone here. Adjusting analysis for groups with high collision. Okay, we'll keep that. That's good. That would be easier to type in the chat sometimes. All right, I am ready to move to our next section, and I'm going to turn it over to Dr. Nicole Sanders and Mike Motley to talk about methodologies for developing project-specific events and episodes. Nicole and Mike.
Hello. I will actually, this is Nicole, by the way, in case you couldn't guess that. I will actually be the one speaking today. So when we are talking about any of our studies, all of the parameters we ever consider for any study is based on our study questions, okay? What I'm showing here in general, well, here are the general parameters that you might want to consider for when you are trying to develop. Hang on one second. Okay, so anyway, methodologies for developing project-specific events and episodes. Yeah, I'm sorry, you guys. I'm getting a little distracted by things that are going around. Okay. So in general, here are the parameters that we consider. Okay, the primary parameter might be the triggering event. Ooh, I have mouse control. Thank you, Kathy. For example, a triggering event could be defined by a particular procedure, or perhaps it is a particular diagnosis code that occurred on a claim. And this would be used to identify your triggering claim. And that's what you need to determine the rest of your parameters. So one thing you might need to consider is there a pre-period for claims experience inclusion? And I'll go over a few examples in just a minute and show you guys how, like, scenarios for considering this information. Another consideration would be to define the post period for experiences related to that procedure type. So you might consider, do you want to set a number of days where you extract all of those claims that occurred in a specific number of days from the triggering event? Or if you're not exactly sure how long an event might take or an episode might take, you may want to use claims that are within a contiguous series of dates from the triggering event. Let's see. And then finally, you need to, which your end of defined post period falls into that as well. So one final consideration may be that, is there some related care that may have occurred on subsequent non-contiguous days or outside of a post period? So like if there were follow-up visits, that's the kind of situation you would want to think about. So let's go over a couple of examples. Suppose you are interested in emergency events. Oops, let me move that. Emergency department visits. So your triggering event would be an emergency department visit. Now, depending on maybe your diagnosis of interest, or maybe a certain group of people, really, you might want to consider a diagnosis of interest. Do you want to look at a pre-period for that? Like, did they have any follow-up visits preceding the ED visit? Perhaps an ED visit could have been avoided. Another thing you might want to do with ED visits is look to see if there was an associated inpatient stay. And for us, we usually look at the date of service from on an ED visit and see if there's an admit date within 24 hours of that time period. Another example would be colonoscopies. So for colonoscopies, you would use a particular procedure code, or at least we would use a procedure code. An example would be perhaps you wanted to look at colonoscopies with or without anesthesiology. Well, you can't just pull the claim for a colonoscopy or pull a single colonoscopy record because anesthesiology is a whole separate claim. So you would need to pull all of the claims that occurred on the day of the colonoscopy. And theoretically, all of those related claims should be on a single day. And then, so another example is tonsillectomies. So for a tonsillectomy, again, you'd have a procedure code that you might be using for your triggering event. And you may want to think about a day, maybe looking for any claims that occurred the day before, because maybe those would be prep, any claims related to prep for a tonsillectomy. And then, you know, how long do you want to look out past the actual event? Like, how long was the hospital stay? They probably shouldn't have had a hospital stay. That should probably be an outpatient procedure. But talk to your SME about that. And then, you know, do you want to include the follow-up for the tonsillectomy? Because I'm sure there would be one. And then finally, deliveries. These are very tricky. We just spent a lot of time working on deliveries. So we have procedure codes that we can use to identify a claim for delivery, for a delivery. And we have diagnosis codes that indicate whether or not there was a birth. But you got to think about it. Do you expect a birth to occur on the admit date, or could there be multiple days before the birth actually occurred? And you got to think about, again, there's going to be facility claims and there's going to be professional claims. And if you're looking at a delivery or a birth, you want to look at that whole, everything that encompassed that time period. So maybe you want to look at some dates, like a date after the discharge date from the hospital stay. So yeah, those are some really high level examples. If anybody, does anybody have any questions about that? And of course, you can always email us to ask for any advice related to how we might do it.
I don't see any questions in the chat at this time. Nicole?
Excellent, then that will be all.
All right.
Oh, yeah. All right, everybody. Well, I have a question before we answer this. This is Kenley. Tell me again, Nicole, have you found that there are easier events or events that occur more logically than others?
I would say deliveries are not the most logical.
Mm-hmm.
Unless you've experienced one, then maybe it'll make sense to you. We have had trouble with colonoscopies before. Colonoscopies are tricky. Surgeries that, because we've also looked at knee replacement surgery, that can get tricky because you need to talk to your SME, of course, to figure out, to at least get an idea of how long care should occur. So yeah, always talk to your subject matter expert when determining where to start, at least. Right.
I'll emphasize what Nicole says about your subject matter expert. And we have within our analytic group some MDs, and they are able to put into context the noise that you see in the claims. And so, and Nicole, I think you would agree that it would be very hard to do without them. So very hard.
Yeah.
But I asked that question because depending on the analytic subject, you could end up with some crazy complicated thing you have to research, and it might be worth looking at something a little more straightforward first, just to get the feel of picking your trigger event and looking back and looking forward and understanding how hospital stays work, where, if that's what it is. A little practice makes perfect is what I have observed.
Yeah, definitely. explore your data, try something simple first or
Mhm.
something related. Also, let me tell you this, not every submitter bills the same way.
Yeah.
Deliveries are especially tricky because we have submitters that will have lump claims that will roll up prenatal and delivery care. So
Mhm.
just be aware of those things.
Mhm. Yeah.
This is Mike. I would just like to add, and great job, Nicole, that
Thank you.
for a lot of the events or the procedures that are identified, there are oftentimes external sources that can validate kind of a statewide volume of these types of things. And so you can kind of check your
Yeah.
outcomes against some of those published things. And that's helpful to kind of
Oh
hone
yeah.
your methods.
Mhm. Not everybody does it the same way. So.
No.
All right, we've got some responses to our first question. Anybody else out there? Okay, let's go to our next question. Let's see. I know this is such a broad topic, so. Hang on. Yeah. Yeah. And then in the chat is methods for setting event boundaries. Yep. Uh-huh. That's events of interest in Arkansas. Excellent. Good. Yeah. So in response to the last thing that was written here, events of interest in Arkansas, Mike and Nicole, where do your research topics come from usually?
Mike, you want to answer that?
Sure. So there are, well, number one, there are any events where there's a great volume of them, like deliveries or births is one of the highest volume inpatient activities. And so if there's a high volume, if there is a
Legislative question.
yeah, there's a legislative question, if there is a perceived variation in a outcome or a cost of an event across providers or payers / submitters, if that is something that that is in the policy environment, that might be something that we look at. There are also kind of standard quality measurement benchmarks around preventive screenings and things like that are the HEDIS measures, if you're not familiar with those, out of the AHRQ. I'm throwing out a lot of acronyms, but there are some national groups that put together basically, in lay terms, a recipe for how to measure events. And then we'll end up kind of adapting that programmatically and doing a version of that for things like breast cancer screening or, colonoscopies, as Nicole mentioned,
Asthma medication.
child wellness visits, just any host of things that are meant to be preventive that and reduce, downstream negative outcomes. So, and that's of interest to provider groups, health plans. So,
yeah,
any of those preventive visit sort of things are usually things of interest for us. We have a lot of disparity in the state in terms of chronic conditions, and that's pulling us in the right direction to look at those metrics. So.
Cool. Thank you. Let's go to the next question. Oh, okay. All right. The next topic is data field coverages. And this is in response to a survey question that we had about where can we find counts by data element. that was I think I got that question twice. So we do produce a report with each build that can help you out. And so Kathy is going to switch screens. This is on the Arkansas APCD website. And I should tell you that when we post the deck, the link in it will be live. So you'll be able to click to it, but it will take you here. And before we click on a report, actually, no, let's click on a report, Kathy. Let's click on member data, and it's going to produce an Excel spreadsheet. And you would open that up. So we have counts by data element for the fields that are logical. Like we don't have zip codes because that would be tens of thousands of rows long. Did that report come up, Kathy? Can you switch over to that?
Hang on. It's opening and it's giving me that error that they like.
Oh, so just click through that.
Yeah.
Easy for me to
It's
say.
gonna do
There we
it.
go.
It's not gonna do it.
Oh,
We'll move those somewhere where they work.
yeah, where they work. Anyway, mine is up. Can I take?
Hold please.
Make me the presenter. I can.
Try it now.
Okay. Share screen. There we go. Share. Okay. Can everybody see a spreadsheet here that says data element frequency?
Yes.
Okay. So this is what it will look like when it comes up. And it's a 2-tab Excel spreadsheet for each file type. And this tab provides some information like the build it came from and the fields that are profiled here. And if you go over to the other tab, you can, by field, you can see what the counts are. So you'll get some idea of coverage and count. It doesn't give you count by submitter by field, but it will give you overall. So it can help you make some decisions about the use of the field and the values that are in it. Like no value available means there wasn't provided, and it's relatively low compared to, is very low compared to the population of the other. So we wanted to share with you, this is a report and a tool that's kind of buried, and it made sense that we got that question. So thank you for whoever submitted it, and hopefully you can use this tool in the future. All right, Kathy, and let me, you can take it back from me, I think. Or do I need to give it back to you?
Think I can steal it.
Okay.
How about now?
I just see the slide, so I think you've stolen it.
Okay.
All right. So the next slide is another input slide, survey slide. Can you guys throw up a few words there? That'd be helpful. Yep. We'll give a few more seconds. Good. Ah. I think that's a sentence. We'll make that work. Okay. All right. Let's go to the next topic, Kathy. So yes, everybody, if you have a few ideas here, what else would be helpful to you? And then we'll go to the next topic because it's kind of long. An alternative to this would be if you go out to arkansasapcd.net and look at all the reports out there, because there are a bunch, then send us an email if you'd like and tell us what you want or if you have questions about them. Let's move on, Kathy. We have 9 minutes left. Okay. So over the past few months, we've identified some data issues on the Arkansas Medicaid data and have since corrected them. We worked very closely with Arkansas Medicaid to resolve them. These may or may not affect the data you currently have. If you have concerns about these issues within your data, you can reach out to us directly, or we'll reach out to you. I would reach out to us so that we can collaborate. It might go faster. We'll take you through the data changes and discuss the impact of what we found, if there is any impact at all. When you get access to this deck on the website, you'll notice that over in the lower right, there's a blue shape called data tip. And so out on our data tips section, which you can get to from the homepage of arkansasapcd.net, there's a green button that says data tips. So click on that and go to 84. But in the deck, it'll be live. I just can't click it here. So we have 4 Medicaid changes. Let's go through them. Facility type. Oh, wait, go back, Kathy. Right. Facility type, MC037. So Medicaid used to populate this field on every single record with an O2 for everything. And it wasn't, it was problematic, of course, if you're trying to quickly determine inpatient versus outpatient versus ambulatory versus ambulance versus whatever. So we corrected it a couple of releases ago, but the error showed up again, and we have since replaced all the data and corrected all the facility type fields and have ensured that they will not be wrong again. So it is important to note, though, as of 2017, the value O2 represents telemedicine. And if you see an O2 in this field now, it means telemedicine. So if your data has MC037 and you're using it, reach out to us and we will work through it with you. Let's go to the next slide. Service provider data. This change didn't impact a lot, but there was a little change. So let's go through it real fast. The original logic supporting service provider fields preserved null values when the service provider information was not available at the claim line level. The logic has been revised to select the service provider data from the claim header level when the claim line was null. And this change will result in more service provider level data for use in analytics. And they've been corrected for all years of Medicaid medical claims. Next slide shows the fields that were affected. There's your data tip at the lower right. But we saw a change in the population of these fields. It wasn't real big, but we did see it. So it might be interesting if you want to take a look at that. Okay, the next one is ethnicity, ME025. The original logic applied to a general categorization to ethnicity by categorizing all values into 33, which means non-Hispanic or Latino, other or blank, no race selected, or 34, Hispanic or Latino, other or blank, no race selected. Arkansas Medicaid has updated the population of ethnicity, the ethnicity flag with more specific data that aligns with the values described in our Appendix I of the Data Submission Guide. And they've been corrected for all years of Medicaid data. It's important to note that ethnicity is not a required field on our APCD. It is populated where when carriers have it, Medicaid has it, so they populate it. So, but you'll see if you use Medicaid data, if you get new Medicaid data, you're going to see a lot more granularity. And if you do any work like social determinants of health, it could be useful to you. Okay, next slide, Kathy. I am interested in this, your input on this particular question. So. What did you find valuable about this topic? Okay. Yep. Mhm. Okay. All right. In the interest of time, let's move to the next one. Actually, I want to move again because there will be an opportunity at the end for you guys to add more input. Our next release is, we've begun, and it should be complete sometime in September, October. So for those of you who are utilizing subscription, you'll get a refresh. And for those of you who want to look at their Medicaid data from past polls, we can start working on that as well if you need help with it. Next slide. Don't forget, check your tips. Next slide. Okay. As always, check your tip sheets, check your data dictionaries. There are some featured tips down here. In the interest of time, I don't have a lot of time to go through them. Do go out to the data tips and do read them. And because all of them have some import to you, you will be interested in that. So 80, 82, 83, and 87. Well, all of them, but those for sure. Next slide. Reach out to us for any questions. We're here to help you. And then something special. If you're interested in a one-on-one meeting with us, reach out through our technical support email above and request it. Okay, finally, let's do our last couple of survey slides. How would you rate the presentation? And then the next one will be, what topics would you like to see in the future? Thank you. Decent, okay. Understood, understood. Healthy. Mm-hmm.
Thank you for your honesty.
Absolutely. Okay, appreciate it. It's a very complicated subject.
We ready?
Yeah, next slide. What would you like to see in the future? We want to see the inner workings of every project Nicole works on. Yep, more tips. Case study using updates. Okay. Okay,
That's a good
that's
one.
good. More tips. Yep. Mm-hmm, mm-hmm, mm-hmm. Yeah. All right, let's go to the next slide. Would you be interested in a one-on-one meeting with the Arkansas APCD team? I should have made that a yes/no question, but you can just type yes or no. We'll know who typed. Yeah. Or just reach out to us on our email. So. All right. Well, Kathy, let's go to the last slide. Remember, our next users group is October 27th. Follow ACHI and the HTI on Facebook, Twitter, Instagram.
And we're not sending out a follow-up survey, right?
Yeah, that's right. I didn't
Okay.
take that off. Sorry.
Okay.
All right. Well, thank you, everybody. Don't hesitate to reach out if you have any questions. Until next time, bye-bye.